So I want you to imagine you are a physician.
Okay.
You're sitting in this very sterile consultation room. And sitting across from you is a 39-year-old man.
Right.
He has just been diagnosed with stage 1 renal cell carcinoma, which is kidney cancer.
Yeah, but stage 1, so it's caught early.
Exactly. Because it's early, it's highly treatable. The surgical pathways, the therapies, they're all very clear. The survival rate is overwhelmingly in his favor.
That's the best news you can hope for in that situation.
Right. So you lay out the entire treatment plan,
Mm-hmm.
and the patient just looks you dead in the eye and says, no, I don't want surgery. I don't want chemotherapy.
Mm-hmm.
I'm just going to let this run its course, and I'm going to go home and die.
Oh, wow. Yeah, I mean, that is literally the nightmare scenario for any healthcare provider.
Right.
Because every single instinct you have, every year of your medical training is just screaming at you to save that life.
But you also have rules. You have these hospital protocols, legal mandates, and psychiatric evaluations that confirm this man is of completely sound mind.
He knows exactly what he's doing.
Right. He totally understands the consequences.
Oh.
So your institution has a protocol. The law has a protocol. But your inner compass, as a healer, is actively at war with what you are being told to do.
Yeah, it's a massive conflict.
And today, we are asking you, the listener, to step into that incredibly uncomfortable space. We're doing a deep dive into what happens when the rules of a massive healthcare institution go to war with the fundamental ethics of keeping people alive.
What happens when following the rules actually, causes harm?
Exactly. And to explore this, we're pulling from a really fascinating stack of source materials today.
We really are. We've got foundational medical ethics textbooks, university lectures on the core pillars of medicine, and these complex academic papers analyzing regulatory capture.
Right, specifically looking at the Vioxx pharmaceutical scandal.
Yeah, that catastrophic Vioxx situation. But grounding all of this high-level philosophy are the intensely personal, real-life legal documents and writings of a medical whistleblower.
Dr. Srivatsa.
Right. A doctor who basically found himself crushed by the very healthcare system he was, actively trying to protect.
But before we dive into his specific legal battles, we do need to establish a really crucial baseline here.
Yeah, we absolutely have to be clear about this.
The documents we are analyzing regarding Dr. Srivatsa, they contain some very severe, highly charged allegations against major governmental bodies.
Specifically, the UK's National Health Service, the General Medical Council, and the Secretary of State for Health.
Right, and we need to be absolutely unequivocal with you. We are not here to act as a judge or a jury.
No, not at all.
We are not endorsing these legal claims, and we aren't dismissing them either. Our objective is just to impartially examine the contents of these documents and the broader philosophical arguments they present.
Right, we're using his story as a lens, a way to understand the systemic pressures that are facing modern healthcare everywhere.
And that distinction is vital, because the core of his conflict, and really the core of our entire deep dive today, rests on a fundamental misunderstanding. Most of us have about 2 specific words.
Morality and ethics.
Yeah. I mean, in casual conversation, we use them like they're synonyms. I definitely...
Most people do. But reading through these medical texts, treating them as the same thing as well, it's apparently a really dangerous mistake.
A potentially fatal mistake, depending on the clinical context.
Exactly. So let's strip away the casual definitions. In the framework of our sources, morality refers strictly to social, cultural, or institutional rules.
Okay.
It is what society or the legal system or the hospital administration dictates is right or wrong. Morality is just the protocol. It's the bureaucratic checklist.
So I want to make sure I'm visualizing this correctly.
Yeah.
If a hospital administration drafts a policy that says a nurse must fill out Form 104B before administering a specific antibiotic,
Right.
complying with that administrative demand is a moral action within that specific ecosystem.
Precisely. Morality is compliance. Ethics, however, is an entirely different domain.
How so?
It's an inner compass. It's guided by truth, by intention, and by an absolute responsibility to the protection of life.
Okay.
Ethics transforms the highly subjective, shifting nature of societal right and wrong into an objective, universal measure.
So it's like morality is the GPS navigation system in your car.
I like that, yeah.
It's programmed by an external authority. It calculates the legal speed limit, the traffic patterns, and it tells you the prescribed route. It says turn left here.
Right.
But ethics is your own vision through the windshield. If the GPS is glitching and it tells you to drive straight off a bridge into a deep lake, The moral thing, the compliant thing, is to follow the screen and drown.
Which is crazy.
Right. Ethics is the critical human judgment that makes you slam on the brakes, reject the protocol, and protect your own life.
That analogy captures the tension perfectly. When the system harms life, blind obedience to it is no longer ethical. And the whistleblower documents frame this using a concept from ancient Eastern philosophy, actually. Specifically, principles found in texts like the Bhagavad Gita that talk about the concept of dharma.
Dharma. Okay, how does dharma factor into a modern clinical hospital setting?
Well, dharma, in this context, means acting in total alignment with truth and the fundamental protection of life.
So it's not just following orders.
Exactly. It is not about obedience to authority, and it is certainly not about the fear of administrative punishment.
Okay.
If a healthcare system or a medical protocol becomes disconnected from the protection of life, if the GPS is directing you into the lake following, that system becomes adharma.
Adharma, meaning unethical.
Right. It becomes inherently unethical regardless of what the legal department says you should do.
Okay, but I'm struggling to see how that doesn't just devolve into total clinical anarchy.
How so?
Well, if every single doctor on a ward decides their personal inner compass overrides the hospital's rules, how does a hospital even function?
That's a fair point.
I mean, we must have frameworks for this, right? We can't just have rogue doctors doing whatever they feel is dharmic on any given Tuesday.
No, of course not. And we do have frameworks. The medical ethics texts provide 3 primary theoretical lenses to help doctors actually calibrate that inner compass.
Okay, what's the first one?
The first is deontological ethics, which is rooted in the philosophy of Immanuel Kant.
Right, duty-based ethics.
Exactly. This is strictly duty-based. The mechanism here is that an action must be inherently good, regardless of the consequences. You act because it is your fundamental obligation.
Give me the clinical application of Kant, though. Like, how does a doctor practice duty-based medicine?
Okay, so a deontological approach means you always tell the patient the absolute truth about their diagnosis.
Even if it's bad news?
Even if the patient is incredibly fragile, and you know the truth of a terminal diagnosis will cause them severe, immediate psychological trauma.
Wow.
Yeah. The duty to be honest overrides the negative consequence of their distress.
Okay, that feels harsh, but I guess logically consistent. What's the alternative to that?
The exact opposite is utilitarianism, championed by John Stuart Mill.
Ah, the math approach.
Basically, yeah. This is entirely consequence-based. The ethical math here is to aim for the greatest good for the greatest number of people. It's about maximizing overall utility.
Wait, hold on. I need to interrupt there because that sounds incredibly dystopian when you apply it to a hospital.
Dystopian how?
Well, if we are aiming for the greatest good for the greatest number, doesn't that force a doctor to become a judge of a patient's social worth?
It can, yeah.
Like if an ER have 1 ventilator and 2 dying patients, say an 80-year-old retired teacher and a 25-year-old medical student, does utilitarianism dictate you let the 80-year-old die because the 25-year-old has more utility to offer society?
It's a brutal calculation.
That just invites horrific biases.
And your discomfort is exactly why pure utilitarianism is so heavily debated in medical ethics. It feels cold. But the reality is, elements of this framework are baked into modern healthcare administration.
Like where?
Think about how public health agencies allocate limited vaccines during a pandemic, or how they calculate QLOIs.
QELYs, quality adjusted life years.
Right. They use those to decide if a new, incredibly expensive drug is cost-effective enough for a national health system to cover. They are doing utilitarian math. They're calculating the greatest good for the limited budget.
Which brings us right back to the friction between the institution and the individual doctor.
Exactly.
The hospital administrator is looking at a spreadsheet, thinking like a utilitarian. But the doctor standing at the bedside of the 80-year-old patient isn't thinking about population metrics.
No, they're thinking about saving the human being right in front of them.
Right, which is where I'm assuming the third framework comes in.
Yes. Virtue ethics. Tracing back to Aristotle, this approach argues that ethical behavior doesn't come from following strict duties or calculating demographic consequences.
So where does it come from?
It comes from cultivating ingrained moral character traits, things like courage, honesty, deep compassion.
Okay.
The theory is that a physician who continuously practices these virtues will naturally make the right choice when forced to navigate the really gray areas.
And the grayest area of all in these source documents seems to be something called the principle of double effect.
Yes, that's a huge one.
I'm really stuck in the logistics of this one, to be honest. How does a doctor ethically justify taking an action that they know with absolute certainty will cause harm?
It's tricky. The principle of double effect, which is often attributed to Thomas Aquinas, is basically the mechanical breakdown of intention.
Intention, okay.
It recognizes that in medicine, a single action often has two parallel consequences. One is therapeutic, and one is deeply harmful.
Like what?
The texts use the administration of high-dose morphine to a terminally ill, agonizingly painful patient as the definitive example.
Okay, walk me through the physiology of that. Why is morphine the classic example here?
So morphine is a powerful opioid analgesic. Its primary function is to bind to receptors in the central nervous system to block pain signals.
Right, that's the therapeutic goal.
Exactly. However, morphine also depresses the respiratory drive in the brainstem. In high doses, it slows a patient's breathing down, sometimes to the point where they stop breathing entirely.
So a doctor gives the injection, knowing it will stop the pain, but also knowing it might literally stop the patient's lungs and hasten their death.
Yes.
How is that not just legally classified as euthanasia?
The entire legal and ethical distinction rests on the concept of intention, which actually circles right back to the teachings of the Bhagavad Gita mentioned in our sources.
That intention matters more than the outcome.
Precisely. Under the principle of double effect, the physician's primary intention is beneficence, the relief of suffering. The hastening of death is a foreseen but completely unintended secondary consequence.
So if the doctor's intent was to kill the patient to end their suffering, that's euthanasia.
Right. But because the intention is purely pain management, the action remains ethical, even if the timeline of the patient's life is cut short.
Man, that requires an incredible amount of psychological compartmentalization on the part of the physician.
It really does.
You have to be able to look at a devastating outcome and truly know in your heart that your intention was pure.
Yeah, it's a heavy burden.
But let's bring this out of abstract philosophy for a second. How are these theories actually codified into the rules that doctors learn on day one of medical school?
They are codified into the 4 pillars of medical ethics. These are basically the navigational beacons for the clinical compass.
And those are?
Autonomy, beneficence, non-maleficence, and justice. Let's revisit your opening scenario, actually. The 39-year-old cancer patient who refuses treatment.
Right.
That is a direct collision with the first pillar, autonomy.
Explain how autonomy works mechanically in that scenario. Because for centuries, medicine definitely didn't operate this way.
No, historically, medicine was entirely paternalistic. The physician was the absolute authority. They held all the knowledge, they made all the decisions, and the patient's role was just passive compliance.
Just do what the doctor says.
Exactly. Autonomy completely dismantled that hierarchy. It dictates that a patient, provided they have the cognitive capacity to understand the medical reality, has the absolute sovereign right over their own body.
Even if their decision is objectively terrible, like refusing life-saving cancer treatment.
Especially then. As a doctor, you cannot physically restrain that 39-year-old man and force chemotherapy into his veins. You can't manipulate him. You have to respect his bodily autonomy.
But wait, that completely flips my understanding of a doctor's job. Doesn't that violate the second pillar? Beneficence. The obligation to actually do good and heal people.
Yes. It creates massive friction between the 2 pillars. Beneficence is the active pursuit of the patient's best medical interests.
Right.
So in the case of the patient refusing cancer treatment, you cannot just say, okay, sign this waiver, have a nice day, and walk out.
You have to try to help them.
Beneficence demands that you sit down and aggressively educate him. You have to ensure he fully comprehends the brutal reality of how the cancer will progress without intervention. You give him every piece of data, every ounce of therapeutic hope.
Okay, so you fight for him.
You do. But at the end of the day, beneficence is about empowering the patient to make the best choice. It is not about making the choice for them.
Okay, so beneficence is the active pursuit of doing good. That seems to overlap heavily with the third pillar, which is non-maleficence. The famous first, do no harm. Are they not just 2 sides of the same coin?
They're related, definitely, but the mechanical distinction is critical for how a hospital functions.
How so?
Beneficence is about what you actively do. Non-maleficence is about what you actively refrain from doing. It's the calculation of risk versus reward before you ever even touch the patient.
Our sources highlight a liver biopsy as a prime example of this calculation. Unpack that for me. Why is a liver biopsy the perfect test case for non-maleficence?
Sure. Imagine a 56-year-old patient with wildly elevated liver enzymes. You suspect severe cirrhosis or perhaps a malignancy, but you need a tissue sample to know for sure.
Okay.
A liver biopsy involves taking a long, hollow needle, inserting it through the patient's abdomen, and punching a core of tissue out of the liver.
Ouch.
Yeah. And the liver is an incredibly vascular organ. It is full of blood.
So the risk of internal hemorrhaging is massive.
Exactly. Or the risk of introducing a severe infection or accidentally puncturing the gallbladder.
Right.
The physician has to perform a complex ethical calculus. Is the potential harm of the procedure, the maleficence of sticking a needle into a vascular organ, outweighed by the beneficent need for an accurate diagnosis?
Right. What if the risk is too high?
Well, if the patient's blood work shows they have a severe clotting deficiency, the risk of them bleeding to death from the biopsy might be 20%. At that point, non-maleficence overrides beneficence. You do not perform the procedure. You refrain from doing harm.
That makes complete sense. You're constantly weighing the scales.
Yeah.
Which leaves the final pillar, justice.
And the academic lectures we're reviewing make a very sharp distinction here between treating people equally and treating people equitably.
This is where public perception often clashes violently with medical ethics.
Really?
Yeah. Justice in healthcare does not mean an egalitarian free-for-all where everyone gets the exact same treatment at the exact same time. It means the fair allocation of scarce resources based on clinical severity.
The emergency room triage scenario in our notes is brilliant for explaining this. Let's walk through it.
Okay.
A 28-year-old man walks into a crowded ER. He's experiencing severe gas and intense abdominal bloating. He's in pain, he's terrified, he has a bowel obstruction, and he checks in at the front desk.
And then he sits in a plastic chair for 3.5 hours. During that time, he watches 6 ambulances arrive, and he watches paramedics rush those patients straight through the double doors.
Now, from his perspective, sitting in that chair, he is the victim of profound injustice. He followed the rules. He arrived first. Why is the system skipping him?
Right. If justice meant equality, the ER would operate like a deli counter. You take a ticket and you wait your turn, regardless of why you're there.
But medical justice demands equitable treatment.
Right.
The triage nurse took his vitals and determined that while his condition is highly uncomfortable, his airway is clear, his heart is pumping, and he is not in imminent danger of dying.
He's stable.
Exactly. The patients bypassing him in the ambulances might be suffering massive ischemic strokes or penetrating trauma. Justice dictates that the most precious resource in the hospital, the immediate attention of a trauma surgeon, goes to the patient who will die without it in the next 5 minutes.
So the 28-year-old is actually receiving perfectly equitable care within the triage system, even if it feels agonizingly unfair to him.
Precisely.
Okay, so I am looking at these 4 pillars: autonomy, beneficence, non-maleficence, justice. They're logical, they are heavily debated, they are taught to every medical professional on earth.
Absolutely.
So here's my fundamental problem. If the philosophical foundation is this solid, how does the real-world execution fail so spectacularly?
That is the million-dollar question.
How do we end up with systemic, catastrophic harm if every doctor is operating with this compass?
Because the individual doctor's compass does not operate in a vacuum. It operates inside a labyrinthine, trillion-dollar bureaucratic machine. And institutions do not have a pulse. They don't have a conscience. They have priorities. Throughput, budget reduction, liability management, and in many cases, extreme pressure from corporate partnerships.
So the rules take over.
Exactly. When the administrative morality of the institution overrides the ethical pillars of the practitioner, the domino effect of harm begins.
And to truly understand how that domino effect works, we have to look at a macro-level failure. A scenario where the entire regulatory apparatus, the system designed to be the ultimate safety net for the public, simply collapsed.
Yes.
Our sources focus extensively on the Vioxx scandal.
Vioxx is one of the darkest chapters in modern pharmacology. It was a medication developed by Merck & Co., a type of NSAI, a non-steroidal anti-inflammatory drug.
Right.
It was specifically engineered as a KOX2 inhibitor, heavily marketed as a miracle drug for severe arthritis.
I want to understand the mechanism of the failure here. Why did they design a KOX2 inhibitor? What was the intended therapeutic benefit that made the regulators so eager to approve it?
Well, traditional NSAIDs like ibuprofen or naproxen block both KOX1 and KOX2 enzymes. They reduce inflammation, but they also block the enzymes that protect the lining of the stomach.
Oh, I see.
So long-term use for arthritis often led to severe, sometimes fatal, gastrointestinal bleeding. Merck designed Vioxx to selectively target only KOX2, theoretically providing all the pain relief with none of the stomach ulcers.
So it was pitched as a massive leap forward in beneficence.
Exactly.
But the clinical reality was a nightmare of non-maleficence. The data in our academic papers is staggering.
Yeah.
Before Vioxx was pulled from the market in 2004, it caused an estimated 88,000 to 140,000 heart attacks in the United States alone.
It's just unbelievable.
And the fatality rate for those heart attacks was between 30 and 40%. We are talking about tens of thousands of deaths.
This was not a rogue doctor making a mistake during a biopsy. This was a systemic failure. The drug altered the blood clotting cascade, increasing the risk of thrombosis blood clots, which led directly to myocardial infarctions and strokes.
And we have an incredible academic paper from the University of York in our stack that dissects how the UK regulator, the MHRA, previously the MCA, failed to catch this. They explore a concept called regulatory capture. Now, when I hear regulatory capture, my mind immediately goes to Hollywood movies. Executives handing over briefcases of non-sequential bills to government officials in underground parking garages.
And that is a really dangerous misconception.
It's not bribery.
Almost never explicit bribery. The academic research demonstrates that capture is soft capture. It's a slow structural erosion of critical judgment. The University of York paper outlines 3 specific mechanical failures that allowed Vioxx to slip through. The first is information overload, driven by something economists call bounded rationality.
Bounded rationality. What does that actually look like inside a government regulatory office?
It looks like a human being drowning in data. A regulatory reviewer is a person. They have a finite amount of time, a limited budget, and basic cognitive limits. When a massive pharmaceutical company like Merck submits a new drug application for a blockbuster medication, they don't send a simple summary. They submit tens of thousands, sometimes hundreds of thousands, of pages of raw clinical trial data, statistical analyses, and patient logs.
So it's an asymmetric warfare of information.
Precisely. The regulatory agency simply does not have the manpower or the hours in the day to independently reanalyze every single patient file from scratch.
So what do?
They are forced to rely heavily on the executive summaries, the synthesized data, and the interpretations provided by the very corporation that stands to make billions of dollars upon approval.
Wow.
If the pharmaceutical company's statisticians subtly minimize the cardiovascular events in their summaries or frame them as statistically insignificant anomalies, the overwhelmed regulator, suffering from bounded rationality, is highly likely to miss the underlying danger.
That makes total sense. And that leads directly into the second mechanism of capture, the revolving door.
This is a structural inevitability in highly technical fields. Regulatory agencies need deep, specialized scientific expertise to understand these complex new drugs.
Right, you need experts.
And where do they recruit that talent? Usually from the pharmaceutical industry itself. So you have a constant churn. Scientists and executives move from the drug companies into the regulatory bodies for a few years, and then they leave the agency to take massive, lucrative consulting or executive roles back in the private sector.
It creates a subconscious or maybe even conscious conflict of interest. If you are a government regulator, and you know you want to be hired as a vice president at Merck in 3 years, are you really going to be the one to aggressively interrogate their data and block their multi-billion-dollar drug? You're incentivized to be cooperative, not combative.
And that cooperative environment breeds the third and most insidious mechanism, cultural capture. This isn't about future job prospects. It's about a complete psychological merger between the regulator and the regulated.
How does cultural capture actually happen? Is it just going to the same cocktail parties?
It is attending the same scientific symposiums, publishing in the same journals, moving in the same elite social circles. Over time, they develop a shared worldview.
Interesting.
The regulators start to genuinely internalize the industry's metrics for success. The assumption becomes that rapid innovation and bringing drugs to market quickly is inherently identical to protecting public health. The critical adversarial distance required for the ethical pillar of non-maleficence completely evaporates. The regulator stops looking for harm because they are culturally conditioned to only see the innovation.
So the bureaucracy followed all of its rules. The forms were processed, the committees met. The morality of the institution was perfectly executed.
But the ethics were completely abandoned.
Tens of thousands of people died because a system prioritized administrative flow over the critical interrogation of data.
Which brings us down from the macro-level tragedy of Vioxx to the micro-level, deeply personal battle of the whistleblower in our source documents. Let's examine the clinical reality of Dr. Srivatsa.
Right. While Vioxx was about the failure of high-level drug regulation, Dr. Srivatsa's documents pull us right down into the trenches of frontline care delivery in the UK.
Yeah, he was observing systemic failures within the NHS walk-in clinics and specifically the NHS 101 telephone medical helpline.
And his core concern was the aggressive substitution of deeply trained medical doctors with non-medically trained staff.
Exactly. The system was increasingly relying on nurses without advanced diagnostic training, pharmacists, and in the case of the NHS 111 call centers, individuals with absolutely no clinical background whatsoever.
Teenagers, right?
Yes, teenagers to triage complex patient symptoms.
But they weren't just guessing, right? The system defended this practice. The morality of the NHS Trust stated this was safe because these call handlers and non-medical prescribers were using computer algorithms.
Right, decision trees.
They were following rigid, step-by-step decision trees. The institution called this safety netting. As long as the employee clicked the right boxes on the screen, the system deemed the practice to be medically sound.
And this is exactly where Dr. Srivatsa's ethical compass violently collided with the institutional protocol. He argued that relying on algorithmic decision trees fundamentally violated the pillars of both non-maleficence and beneficence.
Because it's too rigid.
Yeah. The prompt for our deep dive today explicitly asks us to explore the clinical examples he provided because they perfectly illustrate why an algorithm cannot replace a physician. Let's look at the first example, newborn resuscitation.
Okay, walk me through the mechanics of that. A baby is born, and it isn't breathing properly. What does the algorithm say to do?
The rigid institutional protocol, the morality of the moment, dictates a very specific escalation path. The guidelines often say, if the infant is lethargic and not crying, immediately apply a bag and mask and push high-concentration oxygen into the newborn's lungs. That is the rule.
But Dr. Srivatsa argued that is an ethical failure. Why? If the baby needs air, shouldn't you give it oxygen?
Because a doctor who intimately understands human physiology knows that pushing high levels of oxygen into a fragile newborn can cause severe oxidative stress and tissue damage, particularly to the eyes and lungs.
Oh, wow.
Ethics, the deep understanding of life, dictates a different, immediate approach. A seasoned physician knows that often the baby just needs aggressive physical stimulation.
Like what?
Vigorously rubbing the back or flicking the soles of the feet triggers the autonomic nervous system to kickstart the breathing reflex naturally.
Following the rule blindly causes unnecessary harm. Understanding the underlying mechanism of the human body saves the life without the intervention.
Exactly. Now let's look at a second, much darker example from the documents regarding non-medical prescribing. Okay. Imagine a patient walks into a clinic complaining of a severe, persistent sore throat. They see a nurse practitioner or chemist who is strictly following a diagnostic algorithm.
How does a diagnostic decision tree actually process a sore throat?
It acts like a series of literal gates. Does the patient have a fever over 38 degrees? Yes or no. Are there white patches on the tonsils? Yes or no.
Just binary choices.
Right. Based on the clicks, the algorithm deduces it is likely a viral pharyngitis or perhaps a mild streptococcal infection. The protocol authorizes the non-medical staff to prescribe a basic antibiotic or medicated lozenges and send the patient home. The box is checked. The system was efficient.
But the human body is not a light switch. It is not a binary yes or no system.
Precisely. And in the specific example cited by Dr. Srivatsa, the rigid focus on the isolated symptom caused a catastrophic failure of care. The patient didn't just have a sore throat. They had underlying, undiagnosed terminal cancer.
Oh my God.
Yeah. The sore throat was not a simple infection. It was a manifestation of profound neutropenia, a collapsed immune system, or an early sign of a severe bleeding disorder linked to the malignancy.
And the algorithm never asked the deep physiological questions because it wasn't programmed to look for cancer in a sore throat pathway.
It couldn't see the big picture.
It treated the superficial symptom, missed the fatal underlying disease, and sent a dying patient home with lozenges.
That is the essence of Dr. Srivatsa's whistleblowing. He argued that allowing individuals without profound foundational medical knowledge to diagnose and prescribe is legally sanctioned, but ethically abhorrent.
Legal does not always mean right.
Exactly. The lack of depth and clinical responsibility in the algorithmic system was actively harming patients.
And it wasn't just individual diagnoses. The documents also highlight broad, sweeping policies that lacked scientific rigor. Look at the NHS 111 fever policy he challenged.
The policy dictated a blanket quarantine protocol based purely on a specific, arbitrary temperature threshold. If a patient called in and their fever was above a certain decimal point, The rule mandated strict isolation.
What is the ethical concern there? If there's an infectious disease circulating, isn't isolation just beneficence for the general public?
It is only beneficent if it is scientifically accurate. Dr. Srivatsa pointed out that the specific temperature threshold being used lacked a rigorous scientific basis for determining actual infectiousness.
Okay, so it was just a blunt instrument.
Very blunt. And the human impact of this blind policy was devastating. Self-employed individuals, gig workers, and people living on the economic margins were being ordered to quarantine, losing their livelihoods, facing financial ruin based on a blunt, unscientific algorithm.
It's the ultimate failure of justice and non-maleficence. The policy was inflicting massive socioeconomic harm without the scientific justification to balance the scales. So Dr. Srivatsa sees these failures, the algorithms missing cancer, the arbitrary receiver policies, the unscientific reliance on checklists. He sees the system harming life. What does he do?
He chooses ethics over compliance. He refused to remain silent. He challenged the General Medical Council. He challenged the operational protocols of the NHS trusts. He escalated his concerns about patient safety and the dilution of medical responsibility all the way up.
I want to be very clear about something that the documents emphasize. He was not fighting individual nurses or call center teenagers.
No, not at all.
He was fighting the architecture of the system. He was defending the truth in medicine and the absolute necessity of clinical responsibility. But institutions do not like being told their highly efficient, cost-saving architecture is killing people. What was the cost of his courage?
Total personal and professional devastation. When you stand up against a system that has normalized its own flaws, you become the threat. The retaliation detailed in his filings is harrowing. He was not hailed as a hero for patient safety. He was subjected to brutal disciplinary inquiries. He was professionally isolated, marginalized by the very medical community he was trying to protect.
The financial toll alone is staggering. The documents recount how the endless legal battles and the loss of his ability to practice drove him to financial destruction.
Yeah, he lost almost everything.
He was forced to sell his family home. He had to take involuntary retirement. He ultimately left the UK entirely, relocating to Germany just to find some physical and psychological distance from the trauma and isolation.
He filed a massive legal claim in 2011 against the Secretary of State, alleging a torturous conspiracy to suppress his evidence regarding unqualified staff practicing medicine. But he didn't even get a trial on the merits of his clinical evidence.
Why not?
The legal documents note that the high courts eventually acknowledged the state utilized a neat, technical swipe to dismiss his claim.
What exactly is a neat technical swipe in a legal context?
It means the institution used procedural maneuvering, perhaps a statute of limitations argument, or a hyper-technical challenge to his legal standing to get the case thrown out before a judge ever had to look at the actual medical records of the patients who were harmed. They didn't win by proving their algorithms were safe. They won by ensuring the debate never happened in an open court.
Our academic sources explicitly link this kind of institutional behavior to the philosophy of Niccolò Machiavelli. When we talk about Machiavellian tactics, we usually mean political backstabbing. How does a healthcare system act like a Machiavellian prince?
Well, Machiavelli taught that the primary goal of any ruler is the preservation of power and the institution, and that the appearance of virtue is far more useful than actual virtue.
The appearance of virtue.
Yes. When a modern healthcare administration becomes Machiavellian, patient safety ceases to be the primary objective. Reputation management, budget control, and legal liability become the true north.
So if a whistleblower like Dr. Srivatsa exposes a flaw in the system that might generate bad press or cost millions of pounds to fix, the Machiavellian response is not to fix the flaw.
No.
The response is to entirely annihilate the whistleblower. The institution protects its own survival over the lives of the patients it was built to serve.
It is the ultimate manifestation of dharma. The system actively harms the life of the ethical practitioner to protect its own power.
Right.
But there is a quote in Dr. Srivatsa's writings, attributed to Albert Einstein, that anchors his entire journey. The world will not be destroyed by those who do evil, but by those who watch them without doing anything.
He watched the system fail, and he refused to do nothing. He accepted the financial ruin, the exile, the destruction of his career, because to do otherwise would have been a betrayal of his inner compass.
Exactly.
But here is the most fascinating part of this deep dive. His story doesn't end in exile and defeat. While living on a pension in Germany, dealing with the profound trauma of his experience, he didn't surrender to cynicism. He innovated.
He realized that trying to force a corrupt, rigid institution to change from the inside was basically impossible. The system was too heavily captured.
So what did he do?
He decided to bypass the institution entirely and give the power back to the public. He engaged in deep meditation to clarify his focus, and he developed what he called the 7-eye vision: integrate innovation to help initially identify infected and isolate them.
He recognized that the frontline failure of the NHS was the triage system. Patients couldn't tell if they needed a hospital, and the algorithms were failing them.
Right.
So he wrote a book titled Maya Brings Tears of Happiness. And he poured his decades of clinical physiological knowledge into developing a mobile app.
The Dr. Maya app.
Yeah.
It was designed using a sophisticated, color-coded symptom combination system. It wasn't a simplistic yes or no decision tree. It was an attempt to encode genuine clinical nuance into a tool that patients could actually hold in their hands.
So they could figure it out themselves.
Yeah. The goal was safe self-diagnosis. It helped patients differentiate between a minor ailment they could manage at home and a severe condition that required immediate emergency intervention.
By empowering the patient directly, he was trying to achieve true beneficence. He was trying to reduce unnecessary hospital visits, ease the crush on the ERs, and prevent the spread of lethal infections like MRSA in crowded waiting rooms.
But getting a medical app off the ground without corporate backing is incredibly difficult.
It is nearly impossible. But then the technological landscape fundamentally shifted. The rise of sophisticated artificial intelligence provided an unprecedented opportunity.
It really did.
Dr. Srivatsa took the framework of his Dr. Maya system, combined with his deep ethical commitment and clinical experience, and he collaborated with ChatGPT.
He built Dr. Maya GPT, an AI-powered system designed to empower patients to understand their health without being subjected to rigid, cost-saving administrative protocols.
And we absolutely have to pause and acknowledge the staggering, almost unbelievable irony of this reality.
It is the defining paradox of modern medicine.
Human bureaucracies, hospitals, regulatory agencies, the NHS were built by people, for people. They were supposed to be the embodiment of human compassion.
They were.
But over decades of efficiency metrics, budget cuts, and Machiavellian management, these human systems became completely rigid. They lost their ability to perceive nuance. They started treating human beings like algorithmic data points on a spreadsheet.
The human institutions lost their humanity. They abandoned the deeply human application of the 4 pillars.
And to restore that humanity, to restore the deeply personal, ethical commitment to first do no harm, a doctor had to turn to a machine.
It's wild to think about.
He had to use artificial intelligence to bypass the compromised human bureaucracy. Dr. Maya GPT is an attempt to give you, the patient, an uncorrupted safety net, free from the institutional pressures that seek to manage you rather than heal you.
When systems violate ethics, trust collapses. Fear increases in the patient population, and medical errors multiply. Dr. Srivatsa's use of AI is an attempt to rebuild that trust outside the walls of the corrupted institution.
We have covered a massive expanse of territory in this deep dive. We started with the theoretical battlefield of Cotton Mill.
We examined the catastrophic bureaucratic failure that allowed Vioxx to kill tens of thousands.
We explored the devastating mechanical failures of algorithmic triage, missing terminal cancer, and newborn physiology.
And we followed the deeply personal, harrowing journey of a doctor who lost everything to defend the truth, only to build a new paradigm from a quiet room in Germany.
As we synthesize all of this source material, there are 3 absolute core principles that echo through every document and every clinical example we have discussed.
The first is the critical distinction we established right at the beginning. Morality follows rules. Ethics protects life.
They are not synonyms. The GPS is not the windshield. And when the two conflict, when the protocol demands an action that harms a patient, Dharma demands courage.
It demands the willingness to face the disciplinary committee, to face the financial ruin, and to say no to the machine.
Because the ultimate lesson from the Vioxx scandal, from the NHS 111 failures, and from Dr. Srivatsa's life is this: true responsibility begins when you question what everyone else blindly accepts.
That is the core message.
And that leaves us with one final, deeply uncomfortable question to mull over as we close. For generations, society has relied on physicians to be the ultimate safety net for our frail human bodies.
We trust their training, their intellect, and their oath.
But as healthcare is increasingly devoured by non-medical administrators, managed by rigid algorithms, and governed by Machiavellian reputation management, who is acting as the safety net for the doctors.
It's a scary thought.
If the institution relentlessly crushes the ethical whistleblower, if it annihilates the individuals who hold the line for patient safety, is the future of truly ethical medicine going to rely less on failing human institutions and more on the incorruptible, ethically aligned programming of artificial intelligence?
It is a question that challenges the very foundation of how we care for one another.
Thank you for joining us for this deep dive into the source material. Until next time.